we're going to do a little bit on STDs, and this is going to be short and sweet because in the original agenda I had 15 minutes, so it was like, man, I'm going to have to talk really fast. But we had a little bit of time, so I won't talk quite so fast. And if you have questions, we've got time for that also. So STDs, STIs, depending on where you're reading, you are seeing those terms used interchangeably these days. Some people say some of the entities are really infections that are cured and are curable and not true diseases. I'm so old, I'm still using STDs, but then sometimes I remember to use STIs. Just know that the terms are used interchangeably and they respond to sexually transmitted diseases or sexually transmitted infections. They're all spread by having oral, vaginal, and sex with an infected person. So it relates to sex and it relates to something infectious. Not all of the STDs are curable. Some can be treated, but we can't cure them, which means I can't kill the causative agent. We've got some vaccines, and one of them specifically is terribly underutilized, so if you have any ways to get that usage up, we'll talk about that. We need to do that. And signs and symptoms are not always present, which, you know, always people will say to me, well, I don't have any symptoms. Well, no, you probably won't. But that doesn't mean the infection isn't there. Okay, so remember that. So testing, treatment, and prevention. Get tested. Testing is very easy now for some of the STDs. It involves nothing more than a urine specimen. Okay, so it doesn't mean you have, for women, you have to get yourself undressed and get up on the table and your legs in stirrups and blah, 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 blah. All those things that we don't necessarily like to do. And for the gentlemen who are always a little leery of being tested because it was a little swab in the end of the penis in the urethra, that always made me shudder when I had to do it because it was like, ooh, this is going to hurt. And I would tell them front because it was. But now I can do some of those testing for the common ones with a urine specimen. So we've got some advantages going on. And if someone is a contact to an STD or they get a positive result, then they need to get treated. You know, and that may seem very logical to all of you, but I'm telling you, there's a lot of people who have a test result that they never get treated, their partner never gets treated, or their partner says, you know, I've been diagnosed and you need to get treated, and they never get treated. So just because it seems logical doesn't mean it happens. Okay? And then once they're treated, obviously no further sex until the partner's treated and the medication has had time to work. What is our biggest prevention mechanism? Condoms, 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 and condoms every time. And then vaccination for those things that we have vaccines for. Okay. So, how are you going to decide if your client is at risk for an STD? Anybody who has multiple partners is at risk. Anybody whose partner has multiple partners is at risk. Okay? If your client's partner, because you're dealing primarily with women in WIC, if the client's partner has sex with both men and women, she's at risk, and she's at higher risk. If there's been a history of an STD, especially within the past 90 days, they're at increased risk. And it's at an increased risk for a repeat infection, not that the drug didn't work. High reinfection rates, because not everybody in the circle got treated. And if your client has a partner that's an IV drug user, they are at risk. Okay, let's look at human papillomavirus, HPV, because this is the one that's in the literature, lots and lots and lots and lots and lots. Causes warts. Is very, very prevalent. And we have two types of the warts. We have the high-risk type and the low-risk type. The low-risk type, just take it off your radar, you don't have to pay attention to it. If it goes untreated and it persists, two very important words, untreated and persists, then we're looking at cancer of the cervix, penis, vagina, vulva, throat, mouth, anus, and rectum. Right now, Mike Douglas has been in the news because he had oral throat cancer and came out and said it was probably related to HPV. Right now, the big incidence of oral, throat, and tongue is in men who perform oral sex on their partners. That is the big high risk where the data is going sky high right now for oral cancers related to HPV. So keep that in mind. You make the diagnosis by seeing the actual wart, or for women on a pap smear that has an adjunct or an in addition to the pap, the screening for HPV. It's two separate tests run on the pap smear. Any woman over 30 and over, should be having a pap smear with an HPV. That is the gold standard of care. You have a pap smear with an HPV test adjunct, and if you're negative, you do not need another pap for 5 years unless you've had a previous history of abnormals. That is the gold standard right now. The best treatment and prevention for HPV is a strong immune system. The body has the capability to clear the virus from the body with no treatment. And it happens greatest in the younger age. So the younger the age, the greater the chances that they're going to be able to clear that wart virus from their body without any further treatment. And that's why there's been a lot of changes in treatment for abnormal pap smears in the young age woman. And from a standpoint of a pap smear, young age is anybody under 30. Okay. We have a vaccine for HPV. It is terribly underutilized. Terribly underutilized. Only about a third of people, women 9 to 26, have had the full series of the 3 shots for the HPV vaccine. We are underutilizing it significantly. Yes?
With the 3 vaccines, can they still get the HPV?
The vaccines protect against the high-risk pieces. There's a vaccine for 16 and 18, which is the bivalent vaccine, and then there's the quadvalent vaccine, which is the 4 high-risk strains that have the greatest potential to persist and lead to cancer of the cervix. So yes, they can still get HPV, but think of the vaccine as a protection and a vaccine for cervical cancer, because that's what it is. But we are terribly underutilizing it in this country. Terrible. Okay, chlamydia. As far as prevalence goes, it's the most common STD we've got. Men will sometimes have symptoms: burning, pain with urination, discharge from the penis. 15 to 20% will have no symptoms, but they'll have an infection. Women usually have no symptoms at all, and the reason for it is because it invades the cell at the cervical level. So the infection is at the cervical level, and there's no symptoms coming forward. One of the things that you may sometimes notice is bleeding in between periods. So women who's had no bleeding or spotting in between their periods, and all of a sudden, out of the blue, come in and start complaining about it. First thing is, have you had a partner change or something's going on that you might have been exposed to chlamydia? Chlamydia in women is a big cause for infertility because it is so silent in women. We have no symptoms, and yet it progresses up the tubes and scars the tubes. And so chlamydia is a great, great cause of infertility in women because it scars the tubes and you have no symptoms. Everybody thinks that to have your tube scarred, you have to have an episode of symptoms that cause pelvic inflammatory disease or PID. Untrue. You can have scarred tubes and never had a diagnosis of PID. It's almost always related to chlamydia. And it's because the bacteria has migrated from the cervix up into the tubes and scarred the tubes. Yes?
So once it's scarred, there's no way for them to
Unscar it? No. No. And it scars. In the tube you have little fine hair called cilia that move the egg and everything along, and they get all scarred up, and so stuff don't move along. So also aside from it is an increase in pregnancy in the tubes, or ectopic pregnancy. Chlamydia, though, is treatable with antibiotics. Zithromycin, drug of choice, 1 gram, pop it in your mouth, good to go. So it's treatable. The problem is it is so silent. And Milwaukee County, because it is so big, does no follow-up on chlamydia positives. Unlike the rest of the world, in the northern part of the state, that all the public health departments follow up on positive chlamydias. Milwaukee is so big and the numbers are so great, that they can't do any follow-up. Okay? So, we've got a hotbed here that, you know, is just the nature of the beast. And because you got a really transient mobile population, sometimes they get screened, and the phone number that they give or the address that they give, you can't, they're gone by the time the follow-up gets there. Follow-up phone call or letter from the screening source. Okay, gonorrhea, or GC for short. Gonorrhea, the high-risk population for gonorrhea right now is men having sex with men. Bad problem in Milwaukee. Bad problem in Milwaukee. Have a hotbed down here. Discharge is usually present. Yeah, in more ways than one. Discharge is usually present in men and women, and they may also have pain with urination and pain with sex. But discharge a lot of times for gonorrhea is very drippy and noticeable from the guys. Gonorrhea can also affect the throat and the anus. It'll live on the tonsil beds and it'll live in the rectum. So multiple sites of intercourse have to be addressed. If untreated, it can affect your joints. You'll have gonococcal arthritis. Okay. The concern about gonorrhea is we have no new antibiotics in the pipeline to treat gonorrhea. Gonorrhea has developed resistance to all of the antibiotics that have been thrown at it, and it continues to mutate. And right now, the treatment for gonorrhea involves 2 meds because we're trying to keep the gonorrhea resistance down because we don't have any new meds in the pipeline. So this is not good. So we need to prevent. Condoms.
Information called
Syphilis, the high-risk population for syphilis is also men having sex with men. Syphilis is different than herpes in that syphilis will give you an open sore that does not hurt. Very round. I saw one case of syphilis when I was doing sexual assault. In all my years, I've seen one case. Very distinctive. People would say, once you see it, you'll know it. And it's very true. The minute I saw it, it's like syphilis. And it was in a kid. It was really bad. Yeah. But the issue is, it didn't hurt. The kid didn't know the sore, and the child had more than one. It didn't hurt. Doesn't hurt. The sore stays about 4 to 6 weeks, and then it heals over and goes away. And then it comes in, gonorrhea has, or syphilis has stages. So the next stage is that rash that shows up on the palms of the hand or the soles of the feet. Very distinctive. Very few rashes act like that. So that's the second one. And if you go to the third stage, then the syphilis invades the brain and you've got bad mental health issues and problems and behaviors and whatnot else. And if you have syphilis, you have a much higher chance of contacting the HIV virus also. Okay. Treatable with antibiotics, big doses of penicillin, but it's treatable. And thank God, syphilis is followed up on by the state, all over the state. So it's treatable. Now herpes, this is not exclusively transmitted, so that you could get herpes other ways than through sex, but sex is also very common. This lesion hurts, so this gives you open painful sores or open painful lesions, unlike syphilis. You can have more than one. There's type 1 and type 2 herpes. We used to think 1 stayed above the waist and 2 was below the waist, and we now know that that's not true, so that the waistline has nothing to do with it anymore. About 1/3 of patients who have herpes or who get herpes will have regular recurrences. And for a lot of women, it's around the time of their period every month. Okay? The first episode is usually the worst. But there are also people who will have herpes, a first-time episode, and never know, and then have a recurrence, or it shows up sometime later. The bad thing about herpes is it's a virus, and you can shed the virus and not know it. So you can expose your partner, and your partner's at risk, but you don't know it because you have no symptoms. We used to teach people that you were infectious when you had the sore. From the prodrome on. The prodrome is the signs that come before the actual sore breaks out. And on recurrences, it's usually numbness or tingling or itching in the area. and it recurs in the same area where it first occurred. And we used to tell people, you know, as soon as you notice that prodrome, numbness, tingling, itching, you need to consider yourself infectious. And so if it's on the genitalia, no intercourse then until the lesion comes and it heals over. We now know that you can shed the virus can be active, and you can shed it and have no symptoms. You will carry the virus the rest of your life, and when it's not active and it's dormant, it rests along the back of your spine, along the nerve ganglia. And so I can treat the virus, I can treat the sore, in that the medicine will help the sore heal faster. So your symptoms are present for a shorter period of time, but I can't kill the virus. Okay? So it's treatable for the symptoms, but it's not curable because I can't kill the virus. Okay. Hepatitis is sexually transmitted, more common than HIV, although most people don't know that. It's an infection in of the liver. It's not curable, but we have a vaccine for it, which is very well utilized now because we started as part of childhood immunizations, the 3 series of the hepatitis B vaccine. So we've made great strides in hepatitis B. We don't have vaccine for hep C though in some of the other subgroups. And there is a recommendation out that all of us baby boomers be screened at least one time for hep C because they're finding that hep C is more prevalent than they thought. And you don't have symptoms until it gets, you get really sick with it. Okay. HIV or immune deficiency virus. Most of us know about HIV. It takes a long time for the signs and symptoms to develop. It's treatable but not curable. It will affect all parts of the body. People can get really, really sick, as you know it. There's been work on the vaccine, nothing successful so far. And there is a recommendation that everybody be screened at least one time in their life for HIV, and then repeat screenings based on potential risk factors and exposure. There is a recommendation that if you are diagnosed with one sexually transmitted infection, that you should have a screening for HIV as part of your treatment plan when you go back in for treatment. But some people are doing that and some people aren't doing it. Some of it is based on cost. There are a lot of what are called rapid HIV tests now. In the old days, you need to have your blood drawn, it needed to go to the lab. There was a lag time of about 2 weeks before you get the results back. There are HIV tests now that are saliva-driven or blood-driven, and you could run the test right there in the clinic and have the result in 20 minutes. Now, it's a tentative result. It all has to be followed up with a confirmatory test, but there are rapid tests now available for HIV that are very easily done in a clinic setting. Okay, Ann. Trichomonas, or trick for short, the men usually have no symptoms. The women usually have a runny, watery, yellowy green discharge. The diagnosis is made in the women. You do have to get undressed and have an exam because they got to take a sample of the secretions from the vagina and look at them under the microscope. But the men then, the partners, are treated based on the women's findings. Trick and the guys live in the prostate, and it's very hard to get, it can live in the bladder also, in the urine. It's hard to get those specimens and spin it down and find live trick. So very often the men are always treated based on the diagnosis that was found in the woman. It's treatable with antibiotics. Okay? Bacterial vaginosis I put in. It's not a sexually transmitted infection, but it can affect pregnant women. Women's chief complaint is they have a fishy odor from the vagina. It recurs, and in some women recurs very frequently. And really what it is it's an overgrowth of the bacteria in the vagina. And it occurs because the vagina is sick. I look at people and I say, your vagina is sick. The acid-base balance is out of sync. And because people say, why? Because the acid-base balance is not, in effect in the vagina. And all of your bacteria and all of your flora have gotten all out of sync of what it should be normally. And it allows the bacteria then that cause bacterial vaginosis to overgrow. So what I need to do is I need to figure out how to keep the vagina healthy. And women will say, I get it every time I have sex. Yes, you do. Because when semen goes into the vagina, it follows up the acid-base balance. Because the vagina is one end of the spectrum of the acid-base balance, and semen is on the other end. And it takes about 24 hours once semen has been put into the vagina with intercourse for the vagina to recoup and get itself back to its normal acid base. And some vaginas have a hard time doing that. And so the women are bothered with BV. And for a while we were thinking, well, we should treat the guys. So we'd give the guys the same medicine as the women. Didn't do any good. So right now the treatment is you treat the women, you treat them when they have symptoms, knowing that some women are going to be bothered with it a lot because we just can't keep the acid-base balance in sync with the vagina, in the vagina, and so they get all the stuff. So why do we worry about STDs in pregnant women? Well, because, for one thing, it can affect the baby. Syphilis, herpes, all can affect the baby, okay? And then if you've got something going on in the vagina or warts at the time of delivery or herpes, you got that issue. And we get bad outcomes. The outcomes aren't good. We get stillbirth, we get preterm labor, we get small for gestational age, we get babies born with the infection, and then we get some of the mental and physical growth retardation. So STDs need to be prevented in pregnant women. So now I am back to that dual protection kit again. Okay, they may not need that EC, but they sure may need the condoms to help protect themselves from getting an STD, which then can impact the baby and impact delivery. And so we've got those. Bacterial vaginosis is notorious for preterm labor and premature rupture of the membranes. Yeah, so we got that going on. Okay. So, what do you want to do to protect your client? Education. Okay. Make sure your client is aware that they have risk factors. A lot of people just think it's not going to happen to me. I don't have anything. He's clean, he takes a shower every day. I'm clean, I take a shower every day. It has nothing to do with that. Okay, all those myths that we hear. So make sure that your client is aware of their risk factors. And then that dual protection kit, so that they've got condoms available at all times to help protect themselves and emergency contraception if they need it. So that's your quick and dirty synopsis of STDs. And so now we got questions. Go ahead.
Quick question.
Yes.
When a doctor does just blood work, do they normally test for all of these things?
No. And some of them are not tested by blood work. So let's start at the beginning and say, okay, human papillomavirus, you make the diagnosis by seeing a wart on the man or the woman, or if you have a pap smear, by having an HPV screening as part of your pap smear. Chlamydia test is urine. Self-collected vag swab, you put a Q-tip in your own vagina and twirl it around, put it in a tube, and give it to the people and they'll send it to the lab, or you take a Q-tip and put it in the cervix. Okay? Gonorrhea, urine, or swab. Okay? Syphilis is a blood test. Okay? HIV is saliva or blood. Okay? Trichomonas is secretions from the vagina with a swab looked at under the microscope. Bacterial vaginosis, secretions from the vagina with a swab looked under the microscope. So a blood test is going to give you HIV and syphilis.
And the urine, everything else.
And urine or swab from the vagina. Urine is chlamydia and gonorrhea. Okay, so chlamydia and gonorrhea are urine. Syphilis and HIV are blood. And everything else is a swab.
So when you do a urine test and a blood test, Are they checking for all of these things that may relate to blood and may relate to?
No, you leave a urine specimen, they might be checking for sugar. Okay, might be checking for a urinary tract infection. So, the message, here's the message. Know why they're taking the specimen and what they're going to do with it. Okay, I can tell you in the old days, not so much anymore now, but every woman who ever had a speculum inserted in the vagina assumed they were doing a pap smear. Not true. Okay, so you may want to educate your clients about know what test is being done when you go to the doctor or you see your clinician, and if they ask you to pee in a cup, why? What are you going to do with it? You want to draw my blood? Why? Maybe they're doing cholesterol. Who's to know? The other thing is people go in and say, I want to be tested for everything. I used to get that all the time. I want to be tested for everything. Why? What are you concerned about? What symptoms do you have? Who have you been with? You know, I know if I was practicing in Milwaukee, I would practice differently than when I was practicing in Barron, Wisconsin. The incidence of HIV in Barron, Wisconsin is almost zero. But if they were traveling and had sex with somebody in Milwaukee, I'm going to look at that risk differently than the partner was local. Okay, so, you know, you gotta know what you're being tested for and why you want to be tested, and educate your clients to give accurate and current information to their healthcare providers. You know, a lot of people assume I can read a mind. Okay? They assume I should know this. Well, I'm good, but gee whizzers, you know, give me a little break here. You know, help me a little bit. So also educate about being a good consumer of healthcare. What are you going in for? Why are you going in? What did they do to you when they were there? Sometimes I could only piece stuff together by what the patient would tell me that they did to them. Did they treat you with pills you took by mouth, or did they give you a shot in the butt? Okay? It was a clue. Shot in the butt. Bet you they treated her for chlamydia and gonorrhea both. Did they treat her for chlamydia and gonorrhea? I don't know. I don't know. You know, so, you know, as people who can provide education, it may be a simple sentence of nothing more than, when they ask you for a specimen, ask what they're going to do with it, and make sure you get your test results. Okay? You know, you do hemoglobin on somebody, you're telling them what it's about, and you're giving them the test result. Same thing. Okay, other questions? That was kind of a long-winded answer for a little question.